Hello everyone. In this presentation, we will talk about the root canal anatomy and the methods that have been used to study this subject. Then, over a series of 3 lectures, we will discuss the steps of access cavity preparation for anterior teeth, premolars and molars. It's very important that you revise the subject of dental anatomy in order to understand the internal anatomy of teeth in a better way, especially that you will be working on extracted teeth in the lab, so we expect you to be able to identify any tooth you will face. Let's get started. A clear understanding of the morphology of a human teeth and the anatomy of the pulp space is essential to achieving the objectives of endodontic treatment. We need to be familiar with the intricacies and complexities that are likely to occur within the pulp space. And it would be great if we can develop a visual picture of the expected location number of root canals in a particular tooth before we start doing an endodontic treatment on it. Now, the pulp space generally is divided into 2 parts: the pulp chamber, which is located within the anatomic crown of the tooth, and the root canal, which lies within the confines of the root. So, the pulp space is composed of a pulp chamber and a root canal, or multiple root canals. Now, the projection of the dental pulp that extend toward the cusp of a tooth is called the pulp horn. So the pulp horn is the most coronal point within the pulp chamber. Now, the main root canal can divide and branch into smaller canals, and depending on their location, these small canals are called lateral canals if they are located anywhere along the length of the root and extend at right angle to the main root canal, or if they are located in the forcation area, they are called forcation canals. And the majority of these small branches are located in the apical part of the root and they are called accessory canals. Almost 93% of lateral canals are located within the apical 3 millimeters of the root. Now, how do lateral canals form? Let's have a look at this picture, which represents the early build stage of tooth development. You can see the inner and outer enamel epithelium. They join at the cervical area of the crown of the tooth, forming the cervical loop. The cervical loop will migrate apically, forming the Hertwig's epithelial root sheath to form the outline of the root. Now, sometimes blood vessels from the periodontium will get entrapped within the Hertwig's epithelial root sheath, forming the lateral canals. Now, although blood vessels and nerves will pass through the lateral canals and the accessory canals, they do not provide the significant blood supply to the dental pulp. So the dental pulp relies mainly on the blood supply that comes from the blood vessels passing through the apical foramen, or the opening at the end of the root, the opening of the main canal. Now, their importance comes from the fact that irritants and microorganisms can migrate through these lateral canals from the dental pulp to the periodontium. So they act as avenues or pathways of communication between the dental pulp and the periodontium. So if the dental pulp becomes infected, then irritants and microorganisms can travel through the lateral canals into the periodontium, forming an inflammation area. These lateral canals and accessory canals are very small and they usually cannot be seen on radiographs. However, there are certain indicators that can tell us that lateral canals exist. For example, on radiographs, sometimes we see a lateral lesion or a radiolucent black area on the radiograph associated with an infected pulp. This is caused by infection or bacteria and irritants traveling from the main root canal into the periodontium through the lateral canal, forming an area of irritation and bone resorption. And this can indicate the location of a lateral canal. Also, after doing a root canal treatment, we usually, after disinfecting the pulp space, we usually fill it with a radio opaque material that is easily visible on radiographs. Uh, Sometimes the root filling material will extrude through these lateral canals, and therefore lateral canals become visible on radiographs after doing a root canal treatment. Um, and also, sometimes you can notice a notch on the lateral surface of the root, and this can suggest the presence of a lateral canal. Now, another landmark that can occur on the apical part of the tooth is the apical delta, which refers to a branching pattern of multiple small accessory canals and minor foramina that are seen at the tip or the apex of some roots. Just like the river delta, which represents small branches of the main river, the apical delta represents small multiple accessory canals that branch from the main root canal. You can see on this image the electronic microscope image showing multiple openings of the accessory canals uh, leaving the tip of the root. Now, as you have seen, the apical part of the root is very complex. So let's have a closer look at this part and identify the multiple landmarks that can occur at the apical part of the root. So the root canal tapers down as you move apically until it comes to the narrowest point, the apical constriction. So the apical constriction represents the narrowest part of the root canal. It lies within dentine just prior to the first layer of cementum. We can also call it a minor apical diameter. Now, after that, the root canal will dilate again to exit the root surface, forming the apical foramen or the major apical diameter. It represents the opening at the root apex through which nerves and blood vessels that supply the dental pulp pass. The anatomic root apex is the tip or the end of the root as determined morphologically. So when you look at the extracted teeth, the tip or the end of the root, this is called the anatomic root apex as you see it morphologically. Now, when you take a radiograph for a tooth, the tip of the root is called the radiographic apex as determined radiographically. Sometimes, if the root is straight, then the anatomic root apex and the radiographic root apex can coincide. However, if the root tip uh, curves buccally in a buccal or a lingual direction, then the radiographic and the anatomic root apex will be different. And we will discuss that just in a moment. Now, the cementodentinal junction is the junction between the cementum and the dentine. It represents the point at which the dental pulp ends and the periodontium begins. Because the pulp has to be surrounded by a dentine, and cementum is part of the periodontium, the cementodentinal junction represents the point at which the dental pulp ends and the cementum or the periodontium begins. It's very important to know that the apical foramen does not usually coincide with the anatomic root apex. So the exit of a root canal, it's not always located at the apical part or the tip of the root. Sometimes, as you can see in this diagram, the root canal will exit on the lateral surface of the root instead of exiting at the tip of the root. This is a radiograph for the, or mainly focusing on the maxillary lateral incisor on the right side. You can see that the shadow of the canal, the black line, the radiolucent line, it's located within the root canal, and it exits the root surface at the lateral surface of the root, while the tip of or the radiographic apex is different from the apical foramen. Now, in this is a representation to, or this is an image to represent the radiographic or the difference between the radiographic and the anatomic root apex. We usually take radiographs. The X-ray source comes from the buccal direction of the tooth. So if the end of the root curves in a lingual or a buccal direction, then when you look at the radiograph, this part will overlap the root part and it will not be visible. So in the radiograph, you will think that this is the apex of the tooth. We call this the radiographic apex, while actually, if you extract this tooth, you will see that the apex of it is different from the radiographic apex. Now, there has been some studies that explored the morphology of the apical constriction of a tooth, and they found that the apical constriction, the traditional single narrow point, it occurs only in 46% of the cases, while in some cases the apical constriction is tapering, or some teeth have multiple constriction, or it can be a parallel area instead of a single point. So this shows you the intricacies and the complexity of the pulp space. Now, the pulp space, the apical constriction, we aim, during doing a root canal treatment, we aim to finish our instrumentation at the apical constriction point. The reason for this is because it's the narrowest point, so we will produce the smallest wound area. When doing a root canal treatment, we remove the dental pulp. The dental pulp composed of blood vessels, cells, and nerves. So when we cut and remove the dental pulp, we will produce the smallest wound area if we end our treatment to the apical constriction point. It also acts a natural barrier or a stop point for our irrigant material. The materials that we use to disinfect the pulp space will not extrude outside because the apical constriction is very small. While if you end your treatment beyond the apical constriction, let's say for example you end your treatment to the apical foramen, which is the wide point at the root surface, the materials that we use, the chemicals that we use to clean the pulp space will extrude and go outside to the periodontal ligament, causing irritation. So that's why we aim to end our endodontic treatment to the apical constriction. The apical constriction is usually 0.5 to 1.5 millimeter coronal to the apical foramen. So the distance usually between the apical constriction and the apical foramen ranges between 0.5 to 1.5 millimeters. However, with age, we know that additional layers of cementum will deposit at the end of the root, at the root surface, causing this distance to increase. So if you have a look at the anatomy of the root of a young patient, you will see that the distance between the apical foramen and the apical constriction is small, while in an older patient, because of the deposition of additional layers of cementum, then the distance between the apical constriction and the apical foramen will increase. Also, according to radiographic and morphologic studies of different teeth, the distance between the apical foramen and the most apical end of the root ranges between 0.5 to 3 millimeters. So as we said earlier, the apical foramen and the anatomic or the radiographic root apex are not coincident all the time. and the distance between the apical foramen and the root apex ranges between 0.5 to 3 millimeters. Now, you might be wondering, how did researchers study the anatomy of the pulp space, the internal anatomy of teeth? This has multiple methods have been used to investigate the internal anatomy of teeth. The first one is using multiple radiographs taken at different angles. For example, if you have a look at the premolar, the tooth with the yellow arrow on, this root has been root canal treated, and that's why you see this white line. Uh, you might remember that the maxillary premolars, maxillary first premolars, will have two roots, a buccal and a lingual or a palatal root. Because this radiograph was taken from a buccal direction, so the X-ray source was coming directly from the buccal aspect of the tooth, both roots were overlapping, so we are only able to see just a single line. However, if we take a radiograph, another radiograph taken from a different angle, we will see that these actually are two separate canals and two separate roots. To make it clearer, if you have a look at this little girl standing behind the tree, this man will not be able to see the girl because she's standing behind the tree, and he's looking at both objects from a straight line or from a perpendicular angle. However, if the man moves into the right or to the left side, then he will be able to see both the girl and the tree. Another way of or to study the anatomy of the dental pulp is using a cone beam radiographs or cone beam computed tomography. This technique uses a divergent conical source of X-ray. It will rotate around the object in a 360 degree. It will rotate around the head of the patient, taking multiple serial projection images. So you will be able to see slices of the tooth. So that's why you can see a and you can use a software to reconstruct these slices, producing a three-dimensional image of the object. So unlike the radiographs, the traditional radiographs that we've talked about, which will show you only a two-dimensional image of a three-dimensional object, a cone beam computed tomography will show you the three-dimensional object, and it will show you multiple slices of the same object. Another way to study the internal anatomy of teeth is using microcomputed tomography. Microcomputed tomography means that you will use a high dose of radiographs or X-ray on extracted teeth. It's not approved to be used on during practice, so you can't use a micro CT for a patient because for a real patient during the treatment, because you will expose this patient to a high dose of radiation, which can have harmful effects. But we used it on extracted teeth to study the anatomy of the dental pulp, and it's similar in concept to the CBCT. It will produce a three-dimensional image of the extracted tooth, and it will provide invaluable information about the internal anatomy of the tooth without having to destruct or to slice this tooth. Then we can use magnetic resonance imaging. It's not very useful because MRI is usually used to study soft tissues, not dental hard tissues. MRI is a type of scan that uses strong magnetic field and radio waves to produce detailed image of the inside of the tooth. It's different from CBCT, it's different from micro-CT, and it's different from the conventional radiographs because it does not use potentially harmful ionizing radiation, so it doesn't use an X-ray. Another artistic or beautiful way to study the anatomy of teeth is using the tooth clearing technique. In this technique, we aim to convert the tooth structure into a transparent structure to study and see the anatomy, the internal anatomy of the tooth. We put the extracted teeth in 5% in a strong acid, like 5% nitric acid or 10% hydrochloric acid, and then we dehydrate this tooth after removing the minerals from it. We soak it in varying concentrations of alcohol, and then we immerse it in various clearing agents like xylene, benzene, or methyl salicylate. The tooth will become transparent, and then a dye will be injected into the pulp space, and you can see the pulp space colored with different dyes and ink, and you can see how complex the root canal anatomy is. You can see that the canals can branch, rejoin, and then redivide, so it's very complex. Another way is using sectioning and dyeing technique. We can section the teeth in cross sections or longitudinal sections and study it under the microscope. Another way to study the internal anatomy of teeth is by visual assessment by using magnification. So in endodontic practice, we use dental loops, magnifying loops with a good source of light to study the anatomy of the tooth. Also, dental microscopes, we can use them also to produce a larger magnified image, a clear image of the inside of the tooth. Now, as you have seen, the pulp canal system is very complex, and the canals can join, branch, rejoin, and they divide. So scientists and researchers have tried to classify the root canal system to make it simpler to study it and to communicate between clinicians. And you have to be familiar with all these classifications. The first one to attempt to classify the pulp space is Weine in 1969. He categorized the root canal system into 4 basic categories. The first one, or type 1, represents a root canal that starts as a single orifice or a single foramen, and then it continues as a single canal, and then it exits the root surface in one apical foramen. Type 2, we have 2 orifices, 2 root canal orifices, and then 2 canals, and then they exit the root surface in one apical foramen. Type 3, we have 2 orifices, 2 root canals, and they exit the root surface in 2 separate apical foramina. And then in type 4, we have 1 orifice, 1 root canal orifice that leaves the pulp chamber, and then it travels through the root as a single root canal, and then it divides into 2 apical foramina to exit the root surface. Another researcher who attempted to classify the root canal system is Vertucci in 1984. He came up with 8 categories. The first one represents 1 root canal orifice, 1 root canal. They exit the root surface in 1 apical foramen. Type 2, we have 2 orifices, 2 root canals. They exit the root surface in 1 apical foramen. Type 3, we have 1 orifice, and then it divides into 2 canals, and then they rejoin to exit as in 1 apical foramen. Type 4, we have 2 orifices, 2 canals, and 2 apical foramina. In type 5, we have one canal, one orifice, and two apical foramina. In type 6, we have two orifices, and then they join into one canal, and then they exit the root surface in two apical foramina. And then in type 7, we have one orifice, two canals, then they join in one canal, and then they exit again, they branch and exit the root surface in two apical foramina. And type 8, we have three separate orifices, three separate canals, and three apical foramina. So we usually refer them to type 1 as 1, type 2, 2, 1, and then type 3, we have one orifice, two canals, one apical foramina. So 1, 2, 1. And then type 4, we have two orifices, so it's two orifices, two canals, and two apical foramina. Type 6, one canal and then two apical foramina, so we refer to it as 1, 2. And then type 7, we have two orifices, they join into one canal and then they divide into two separate foramina, so we call them 2, 1, 2, and that's and etc. This is one of the cases that I have completed a root canal treatment on. You can see that from this view, we have one orifice, one canal, they divide into two, they join, and then they redivide again. Now, that's it about the anatomy of the pulp space in general. Now we will talk about access cavity preparation, which is the first step during root canal treatment. So the major factors that are involved in the development of apical periodontitis are the loss of integrity of coronal tooth substance and the entry of microorganisms into dentine and the pulp space. I want you to learn these words by heart. So in endodontics, the disease that we're fighting against, we aim to prevent and we want to treat is apical periodontitis. Apical periodontitis means inflammation of the periodontal tissues around the apex of the root. And the reason or the cause of apical periodontitis is bacteria. That's coming mainly from the pulp space. So when you have dental decay, when you have dental caries in the tooth structure that reaches to the pulp, and the pulp then becomes necrotic, it will die and it will become infected, the pulp space will become full of bacteria. Then these irritants can travel through the apical foramen and the lateral canals to reach to the periodontium, causing apical periodontitis. Now, during root canal treatment, what we do is access cavity preparation. We want to reach to the dental pulp space, and then we want to clean it using chemicals and small instruments. And at this stage, we call it chemomechanical debridement or cleaning and shaping of the pulp space. After we clean the pulp space, we need to fill it with a suitable root filling material, and that's called canal obturation. The aim of canal obturation is to fill the space and to prevent the travel of further bacteria to the apical part of the root. And then we put a restoration or a filling on top of the tooth to prevent again bacteria from traveling or leaking to the pulp space and infecting it again. In today's lecture, we will complete talking about access cavity preparation in anterior teeth. Before that, let's talk about the objectives. So what are our aims during access cavity preparation? We want to remove all caries that is present. We also want to remove all defective fillings and restorations that can lead to infection again. But at the same time, we want to conserve and maintain the sound tooth structure. We don't want a weak tooth. So the strength of the tooth comes from the dentine and the enamel in the crown part. That's why during root canal treatment, we aim to preserve tooth structure. We also want to de-roof or unroof the pulp chamber. We want to remove the roof of the pulp chamber and clean it from any contents, whether it's vital pulp tissue, whether it's necrotic pulp tissue, whether it's bacteria. We have to clean it. If we leave some pulp tissue or remnants inside the pulp chamber, this can result in failure of our endodontic treatment because we leave bacteria behind. And also it will result in discoloration and darkening in the tooth color. Sometimes you hear patients complaining that after doing a root canal treatment, the tooth has become darker in color. It's not because of the root canal treatment. It's because the root canal treatment was not done properly. It's because we left tissues behind in the pulp chamber, and over time these will degrade, forming products that can discolor the tooth. We also want to achieve a straight line access or a direct access to the apical foramen of the tooth, or at least to the initial curvature of the canal. So we want a straight line access to the root canal in order to clean it as well. Also, we at the same time we want to preserve and not destroy the floor of the pulp chamber. So these are a series of images. A patient came that he needed root canal treatment for the maxillary molar and the premolars. We cleaned the teeth, we removed the old restorations, and we removed the caries underneath the restorations. We replaced the defective restorations with new ones, and then we did the treatment. As you can see, the orifices or the openings of the root canals are visible, and we have a straight line access to the root canals. This step, or the access cavity preparation, is the first and the most important step on which you will build up the other steps of root canal treatment. This is the most important phase during root canal procedure. Now, the outline of the root canal system is determined by the external anatomy of the tooth. So if you have a look at the external anatomy of a maxillary center incisor, you will see, and if you compare it with the internal anatomy of the same tooth, you will see that the pulp chamber and the root canal system is a reflection or a smaller image of the external anatomy of the tooth. And the pulp chamber anatomy will determine our access cavity preparation. So in this central incisor, look at the external surface of the tooth. In your mind, you will visualize the pulp space as a smaller image of the external tooth anatomy. And then your access cavity preparation, the opening that you will make in order to be able to clean the pulp space, it will be determined by the shape of the pulp chamber. So the shape of the pulp chamber of the central incisor is a triangle, with the base of the triangle located towards the incisal edge. So your access cavity will be an inverted triangle with the base located towards the incisal edge. Now let's talk about the morphology and access cavity preparation for individual teeth. We will start with the maxillary central incisor. Now, a newly erupted central incisor will have 3 pulp horns corresponding with the mamelons. The pulp chamber in the maxillary central incisor will be wider mesio-distally than buccolingually. The image you're looking at is a 3-dimensional reconstruction of a micro CT to the maxillary incisor. In 100% of the cases, or in almost all of the cases, you will only have one root canal in the maxillary central incisor. When you plan to do an access cavity preparation or a root canal treatment on this tooth, the best point to start with is located in the middle of the palatal surface of this tooth, just above the cingulum. The cingulum of this tooth is the strength point of it, so we aim not to destroy it during our access cavity preparation. We will need a hard or a high speed round handpiece or a burr. So to do a root canal treatment or an access cavity preparation on a maxillary incisor, we will need a high speed round burr. We need it to be high speed because we need it to cut through the enamel, and enamel is the hardest tissue in the human body. So we need something efficient to cut through enamel. So we use a high speed round burr. The entry point, represented with an X sign here, is the middle of the palatal surface of the maxillary central incisor, just above the cingulum. The direction of the burr should be perpendicular to the palatal surface. Now we will drill through enamel, and then we will drill through dentine, and then you will feel a sudden drop of the burr within the pulp chamber, because the pulp chamber is a cavity. The pulp will be lying through in this cavity, so the dental pulp is soft tissue, so you will feel a sudden drop in the burr within the pulp chamber. At this point, we have to tilt the burr to be parallel to the long axis of the tooth, and then we have to remove the remaining parts of the roof of the pulp chamber. Then we have the lingual shoulder. The lingual shoulder, or a lingual shelf of dentine, is located in the cingulum at the cervical area of the clinical crown, approximately 2 millimeters apical to the root canal orifice. We have to remove it because this is just a bulk of dentine. It has to be removed. If you look at image A, if we leave the lingual shoulder, then the instruments that we will use to clean the pulp space will bend, and there will be stress areas in this instrument, and it won't be able to touch and clean all the root canal walls. However, in image B, when the lingual shoulder is removed, then the instrument will enter the pulp space or the root canal in a straight direction, touching all the walls of the root canal and cleaning it better, reducing the chances of breakage of these instruments and reducing the stress on the instruments. How do we remove or look at this image? In this image you will see the palatal shelf before and after it's been removed. We use Gates Glidden to remove the lingual shelf, which is a flame-shaped instrument or device. You can use it on a slow speed handpiece and then brush off the dentine on the lingual shoulder area. This is the end this is the definitive shape of the access cavity. It is an inverted triangle with the apex located towards the cingulum and the base located towards the incisal edge with rounded angles. The width of the base of the triangle is determined according to the distance between the mesial and the distal pulp horns. This is the final image after preparing an access cavity or a maxillary central incisor. Now, the maxillary lateral incisor is not different from the maxillary central incisor. The pulp chamber is wider mesiodistally than buccolingually. These are the only two teeth where the pulp chamber is wider mesiodistally than buccolingually, while you will see later on in the other anterior teeth, the pulp chamber will be wider buccolingually than mesiodistally. But in the maxillary central and lateral incisors, the pulp chamber will be wider in a mesiodistal direction than in a buccolingual direction. Because the maxillary lateral incisor is smaller than the maxillary central incisor, your access cavity preparation will be smaller. So the opening that you will make to clean the pulp chamber will be smaller. The maxillary lateral incisor usually has two or no pulp horns at all. Uh, Again, we have to use a high-speed round burr. The entry point will be the same in the center of the palatal surface of the tooth above the cingulum, preserving both the cingulum and the incisal edge. And then we use, after we feel the drop in, then we tilt the burr to become along the long axis of the tooth to become parallel to the long axis of the tooth, and then we remove the roof of the pulp chamber using brushing motion with the same burr, and then we remove the lingual shoulder or the palatal shoulder using Gates Glidden. Usually, we have one root canal in the maxillary lateral incisors. However, sometimes or some patients will have some anomalies or variations in the shape of the lateral incisor. For example, this patient has big shaped lateral incisors, so the access cavity will be oval instead of triangle. And sometimes we have grooves or indentation within the or a condition that's called dense invaginatus, where the enamel invaginates through the root surface, and it will be difficult to treat. You will study this condition in details later on. This is how it looks like, so you will feel like there's another tooth within the tooth, and the access cavity of course will be different in these teeth, and the treatment will be different. Now, moving into the maxillary canines. The maxillary canines, almost in all the cases, they have one canal. The maxillary canine is the longest, it has the longest root within the maxillary teeth. The pulp chamber is wider buccolingually, unlike it's different from the maxillary lateral and central incisors. It has a single or no pulp horn, and the axis cavity will be oval in shape because it has no pulp horns. So we don't have to extend our axis cavity mesial and distal. It will just be oval in a buccolingual direction. The entry point will be again in the center of the palatal surface of the tooth, above the cingulum, preserving both the cingulum and the incisal edge or the cusp tip of the canine. And then we tilt the burr in a parallel direction, we brush and remove the coronal part or the roof of the pulp chamber, and then we have to remove the lingual shoulder using Gates Glidden. The mandibular incisors, the mandibular central and lateral incisors, in most of the cases, they have a single canal in 95% of the cases. But sometimes we can have two canals, a labial and a lingual canal within the root in 5% of the cases. The pulp chamber will be wider buccolingually than mesiodistally, and the axis cavity will be oval in shape in a buccolingual direction. The entry point again will be in the middle of the lingual surface of the mandibular incisor, in using a round burr, a small burr, perpendicular to the palatal surface or the lingual surface of the tooth, and then we extend it buccolingually, trying to preserve the incisal edge and the cingulum as much as we can. And then we use Gates Glidden to remove the lingual shoulder if it's visible. However, in the mandibular incisors, the lingual shoulder will not be prominent as it is in the maxillary incisors. This is how the axis cavity will look like on the mandibular incisors after completion of the axis cavity. Now, the mandibular canines have the longest roots amongst the mandibular teeth. In 94% of the cases, they have just one canal. However, in 6% of the cases, they can have two canals located in apical and the lingual direction. The pulp chamber will be wider buccolingually than mediodistally. So therefore, the axis cavity is usually oval in shape. The steps of the axis cavity preparation are similar. We use a round burr on a high-speed handpiece. The direction will be perpendicular to the lingual surface. The entry point will be in the middle of the lingual surface above the cingulum, and then we move until we feel the drop. We drill through enamel and dentine. We feel the drop within the pulp chamber. We extend our cavity, buccal and lingual, until we deroof the axis cavity, and then we remove the lingual shoulder using a Getz glidden. That's it for axis cavity for anterior teeth. In the next lecture, we will talk about axis cavity for premolar teeth.